All right, welcome back. I hope you're having an amazing time so far. Our next speaker is Dr. Smith. He is a Senior Director, Advanced Analytics at St. Luke's Health System. Please join me in welcoming Dr. Smith to our virtual stage.
Hello, thank you very much for that wonderful introduction. I'll get my slides up here and start sharing those. Start the presentation. Here we go. Thank you very much for attending and coming today. I have some exciting use cases to share with us and discuss as we go through this session this morning or this afternoon. I believe it's this afternoon this will be taking place. We're going to talk about some healthcare use cases for machine learning and advanced analytics. My name is Justin Smith. I work for St. Luke's Health System in Boise, Idaho, and we cover the southwest portion of the state of Idaho. I think what to take away from our St. Luke's snapshot here is we are a small to medium, large scale system enterprise level. So we have 8 medical centers, almost 350 clinics and centers. We cover and serve roughly about 1 million patients or so. And so all of the tasks and questions that we get asked to help provide solutions for are really truly at enterprise scale. And so we try and apply machine learning where appropriate at those levels. This is one of my favorite slides I very much enjoy sharing, living the advanced analytics dream, right? And so we work very closely with our stakeholders in all sorts of areas of the business. And again, I've chosen 3 separate use cases to kind of cover that. And I think this is something where I'm very appreciative for St. Luke's in terms of how we think about utilizing and implementing our machine learning solutions is at the enterprise scale and not just super down and very specific smaller scale types of solutions. So the 3 areas we're going to talk about today are we're going to do one use case for COVID-19 predicting utilization. Perhaps you've heard of COVID-19 in the pandemic that we are all still enduring. We're going to talk about a supply chain solution and a purchasing engine that we created. And then in addition to that, the third example will be demand-based staffing with the idea of optimizing staffing to match patient demand. So right into our first use case. One of the things I'd like to say to kind of start this portion is I am so humbled and appreciative of all of the hard work that's gone on throughout the pandemic, from everybody that's on the front line, the patient care side, all the way back to individuals that I get to work with in digital analytics here at St. Luke's Health System. We really had an incredible response, specifically as the pandemic was starting, mostly because we really didn't know what was going to go on. And as you can assume, as you all can understand, data is the lifeblood of what we do. And when we don't have any data, more or less on a specific problem, it's really, really tricky. And I'll talk about some of the specifics of that here in a moment. But kind of the backstory behind this is we have a few individuals on our team and in our department that are military veterans. And one of the things we talked about right away and they brought forward as an idea was they wanted to create a patch, a morale patch for us. And so what we did is we created this patch that it's, the regular size patch is probably 3 inches by 3 inches or so, or a regular size shoulder patch. And it was really powerful in terms of we gave them out to everybody that was on the team. And then we had a few back that we kept. And so when we would meet with individuals from the state of Idaho or from around other systems or, however we were able to interact with those individuals, we would give them a patch. It was kind of one of those really fun moments of we're in this together and we have to try and find and build solutions to meet this problem. So the question posed to us was this idea of, the pandemic is more or less starting. We have very little to no data on what's going to happen. And we were receiving all sorts of wild predictions and forecasts. But what we wanted to know was, can we predict or expect what's the number of COVID patients that are going to be in our system, both in the ICU and in the general hospitalization area, right? It's hospitalization floors. And we didn't focus very much on emergency department for this specific use case, but I think it's very very poignant to understand, what is our current state for COVID patients in the system, and then also what does it look like in the near and medium term future. So the problem with this, right, was that as we all know and expect and remember, the forecasts for COVID and how it was going to spread through populations were all over the place. Right, we had some places in the country. I have friends that work in New York and New York City specifically that were experiencing extreme numbers of COVID patients and just having really kind of horrific events unfolding, unfortunately, in the spread of the disease there. Whereas at the same time in Idaho, We were not experiencing that yet, and we were unclear if we were going to experience that massive surge or wave like larger, highly dense populations. And so we started to do was look at what is it that we do know, what can we control, and what can we predict from that. And so we went ahead and we developed two kind of, one more on the machine learning side, one more on just sort of a more simplistic machine learning side, I would say. But we developed a short-term forecast for 1 to 2 weeks, and this was a linear and a logistic regression, right, based on more or less just what is happening with inside the hospital census for the previous weeks leading up to that. It's 21 days previous to the day we were trying to predict and beyond. And then we also came up with a XGBoost models for a medium-term forecast that was up to 30 days out. And what was fascinating with this newer technique that we hadn't used and implemented before with XGBoost was that we were able to get within roughly 5 to 6 patients almost a month out using variables like, inpatient census, our positivity rate from our health system. Excuse me, again, we as St. Luke's, especially in the beginning of the pandemic, we controlled or had about 90% of the testing that was going on. So we had a really good pulse and data on, what the number of positivity rates was happening in the community. And so from there, that was another very much driving variable for us. And there's some other things we put in into that model as well. One was the stages of reopening that we were in, how locked down are we or not. We also looked at, but did not include things like patient mobility based on some donated cell phone mobility data. That was not a part of this model, but it was also interesting to take a look at. But back to back to the XGBoost model. I have an example I can show you in the next slide, but it was fascinating because we were able to show with relatively strong accuracy. I mean, I would say strong accuracy where we were going to be, if we're going to be increasing or decreasing in our patient census and our ICU census going out to 30 days, about a month in the future. And from this, one of the things I'm proud to share is that we were able to, we were asked to submit for, and we won an award for the Aegis Graham Bell Award for combating COVID-19 with artificial intelligence out of India, which was a very interesting experience. And it was kind of heartfelt in terms of, we were working as hard as we could with very little data and able to show and help make decisions, help to drive those decisions for the health system on what we should be doing to combat COVID. So here is the example, right? So I've got on the left here the short-term forecast, and you can see, I've blurred this out for privacy, but this is a good example here on the top right portion for the short term is you can see the linear trajectory versus the polynomial trajectory where it looks like we've hit a top of a peak and we're starting to go down, even though the linear model says we should still be potentially increasing. And what we tell our operators is comparing the top right graph in the left-hand panel to the top left graph is the top left graph looks like it's still increasing and we're still gonna be seeing some increased patient volumes in that specific area, that ICU, but it looks like the other ICU area for that system, that hospital ICU area should be potentially decreasing. And then if we go over to the medium term there on the right-hand side, this is the XGBoost model. And so it's forecasting out, see the far right-hand side there, there's a vertical line and kind of the dots get a little bigger and fatter. Those are our projected forecasts for census for those 4 major medical areas, the hospitals specifically. And what we can see is, some are staying relatively flat, some are look like they're increasing. And then on that bottom right, when it looks like there will be a potential increase in census volumes over the next probably 15 to 20 days or so. So again, providing these tools to our operators and decision makers during a time of a lot of uncertainty was a very humbling experience, and I was happy and humbled again to be able to say that we were able to lean in and provide some levels of expertise using machine learning. All right, our next example, moving away from our pandemic and going into a much more business-oriented supply chain model. And so we were asked by our supply chain, can we help develop something along the lines of like a purchasing engine? And that's sort of what we ended up calling it. And the problem was, can we optimize this to decrease our spend per category? When I say category, I mean like medical or consumable. And as you can imagine, in a health system, we purchase all sorts of items from, as I have listed, 100+ vendors and over 400,000 products that we're purchasing. And what we found was the problem in this area is that with such levels of complexity, it's too large for a human to actually take, like, this is not a problem that you can solve on Excel. It's how to decrease spend and, optimize the level of cohesiveness between vendors, and you get different pricing structures as well. A lot of it I'll talk on the next slide is you have to buy a certain level of product to be able to get a certain amount of pricing. And so what we saw happening was that our analysts, to the best of their knowledge, and they're working very hard in this, they were picking known areas that they were experts in or had dealt with in the past. So they're picking specific areas or vendors that they knew and they knew how to work with. There's lots of processes involved in the back end, but basically it was just too large of a problem. So we were able to articulate to the group that really this is sort of a streetlight problem at this point, right? So if the story goes, perhaps you've heard this, that you're walking around and you're going to your car in a parking lot and you realize you've dropped or lost your keys. So the first place you go to look is underneath the streetlight because there's light there. Is the probability of finding your keys under the streetlight high or low or medium? Nobody knows, but that's the first place you look just to make sure you rule it out. And so that's kind of what our analysts were doing, was going to these streetlight portions of areas that they knew where there was light, or they could have some insights to be able to try and solve for optimizing pricing for supply chain spend. So what we were able to do is much more along the lines of an advanced analytics solution. We were able to develop algorithms that generated billions of scenarios. And so I'll pause there because when we had the output come out, right? So we were able to enter in all of these different potential scenarios and have them come out with the potential inputs. The first conversation that we had as a team was, okay, we know there's a lot of good use cases in here where we can definitely save money, but uh, how do we visualize, or how do we show a billion outputs, or billions of scenarios and outputs that can happen? And it was a problem we wrestled with in terms of, we don't want to show individuals everything because that's not comprehensible, but we don't want to show them too little either. And so I've got the next slide. It has a nice little example of the visualization that was created. But what we were able to do was eliminate the non-viable scenarios, right? So we wanted to make sure we stayed within our spanning agreements, and we had to spend X with a certain vendor to get Y price. So that was kind of our first pass. And then the other pass we used was that we wanted to make sure we had the most savings with the fewest number of transitions. And so to explain kind of the fewest number of transitions, right, we have a toilet paper example because, again, going back to the COVID example, hopefully we didn't all have to experience this, but toilet paper was tough to come by for a little bit of time there. So the example for the number of transition is toilet paper from vendor A, right, costs a certain price. Vendor B sells paper towels for less, but as we all know, paper towels are not toilet paper, right? So that would be, if we were asking somebody to make a transition, it would be going from toilet paper to paper towels, which is not what we want to be able. We want to be able to exclude those types of scenarios. And then we were also able to incorporate physician preference for which brand of toilet paper they preferred. So we were able to incorporate individual humanistic kind of, not loyalties, but just preferences, I would say. And again, we want to make sure we're providing the best care and the safest care for our patients. And our physicians have clearly a large say in which products they would like to be using to accomplish that goal. So here's an example of the output. I've blurred out a large portion of the savings is here on the x-axis, and on the y-axis here is the number of transitions. And this looks like, I think we filtered it down. These are kind of the top 20 scenarios, and I think I didn't blur it out enough, so you can see this is for our heart and vascular area. But what you'll notice is when you look at the graph on the bottom left-hand corner, right, this would be low savings and low number of transitions. So technically we could go after those groups, but let's go up to the far right-hand corner, the upper right-hand corner. And this is massive amount of savings potentially, but also a massive amount of transitions. And so those are not what we're looking for either. And what we were trying to focus on, what we were able to do and we're accomplishing now over a series of years as we go through these contract renegotiations, or as vendors approach us with new pricing scenarios, we're able to incorporate those in the model as well. But what we're able to do is we're able to look and see what is it that we have a large opportunity for a low amount of transitions with the high potential for savings, right? And so we're able to pick kind of from this area here, kind of on the far right-hand side near the bottom right-hand corner, to say these are the scenarios and these are the areas of opportunity that we have to provide high and low savings with low transitions for the physicians and across actually the whole health system for both medical supplies and consumables. And so this is being rolled out across the enterprise. And again, it'll take a few years or so before we can really kind of bite our teeth into and sink into all of these negotiations and implementation portion. But it's very, again, very powerful to be able to say, this is an area of opportunity that we have that we can really focus on low transitions, high value of savings as we switch, say, these 5 or 6 products between vendors if needed or more. So that was a fun project. And then the last scenario that I have is based on our demand-based staffing. And so as a healthcare system, we have many, many, many different departments, as I showed on that first slide. And we also have the issue of the opportunity to try and staff towards what's our demand. Meaning, if we have a department or a floor that is historically extremely high in volume, meaning they have a high census, that's full, the beds are full constantly, more or less. We want to make sure we're staffing appropriately. We have legal limits that we have to make sure we have enough nurses per patient and all those type of logistical demands that we incorporate into this. But as well, the idea of we don't want to be overstaffed, but we don't want to be understaffed. And so we want to optimize our staffing to match our historical patient demand. One of the things that's fun with this, I'll talk about in the solutions portion, is we're able to even include 2020 data into this model that's being run currently. As we all know, COVID did very wild things to our census. But again, the problem statement for this is essentially we have a large cost associated with the labor costs for the on-call roles, and also it's unfortunate for us when we have to send individuals home when demand is low, meaning at certain times of the day, because again, hospitals and health systems are open 24 hours a day. When demand decreases, it's not productive for us as a health system to have a department be fully staffed through the low hours of the night when census is very low, and you end up getting individuals that are not being mostly optimized for the benefit that they're able to provide. So what do we do? The solution that we created was, again, we're still rolling this out for the full enterprise. We have it running in certain departments, which is very exciting, and the feedback we've received thus far is pretty fantastic. But the solution is we're able to create and build these algorithms that we're able to offer an optimized schedule that matches staffing and census based on predicted demand. Meaning, over the last 3 years, including 2020, how has the demand over a 24-hour period over a series of a week, how is it structured, and what is it doing historically, and then also where are we today? And we've built in the machine learning portion to say where does it look like we're going to be for the next week or 2 weeks, and be able to build staffing associated with what's going to happen for those next 2-week segments. And I believe we have it built now to 4 to 6 weeks as well, so we can kind of start to do some planning there. And the interesting part from my perspective, what makes this a very intricate problem to work on, is we have multiple roles, right? So we'll have nursing assistants, we'll have RNs. We did not include physicians in this. That was not portion of this scope. We potentially have discussions now to start this with some of the physician roles within the hospital. But for this example, this is nursing staff specifically and some other support staff. But what role do we need to have on the shift at what time? And then we have a prescriptive output that we were able to put out, and I've got a great visual of that coming up here in a moment. But essentially, the output that we provide goes into a visualization, and then that visualization produces essentially a digital copy that then can be input into our scheduling system. And so the nice part with that is going down to the last bullet point, this allows for human intervention to adjust the schedule based on essentially what we call frontline knowledge, right? And so example of that would be if we know we have a Boise state here in the city of Boise or elsewhere, if there's a large event taking place, right, there might be an increased demand for that. But then when we start to see the demand increase greatly is when we have multiple large scale events happening at one thing. So say it's a massive rodeo, or it's it's a big BISU football game, and we have a music festival going on, all within the same weekend. The machine learning algorithm may or may not pick that up, depending on if it was historically in the exact same weekend, the last 3 years or not. But humans know that, right? And so humans have the ability to adjust this output as it goes into the scheduling system. But what's nice for the output that comes from the machine learning portion is that, the example, say we have a need for 6 RNs from the 7 a.m. to 7 p.m. shift, but then we might just need 4 RNs for the 9 to 5 shift. So make sure we build that coverage so it's most appropriate. I think retail has had systems like this in place for a long time, and perhaps there's vendors out there that also offer these solutions, but we were asked to help create this internally specific for us at St. Luke's, and it was exciting for us to be able to work to be able to build this. Now we've deployed it in certain areas. And these schedules are produced on a week-by-week basis, again, up to 4 to 6 weeks out in the future. But the idea where they're able to see kind of what does demand look like as they go into these next future states. All right, so here is, again, I apologize, but it's a blurred out visual. And so you can kind of go through, and this is all, we're a Power BI shop as well. And so you can go through, and it's the output, the data is then generated into a visualization in Power BI. And you can start to see kind of in this lower right-hand portion here, this is the hours of the day, and you can see the colors code to how many nurses or which role of how many roles you will need to have in those areas. You can kind of see as you go over a 24-hour period, as it starts from a certain time, I believe that's probably 7 a.m., you start to see how many of each role you're going to need as it goes through the day, and you can very clearly see that the bulk part of the census, the peak of the census, will be in this mid portion of the day here, as usually typical within health systems, where you kind of have a peak in the middle of the day and people get discharged, and you have admits that kind of trickle in throughout the night, or the afternoon, evening, and nighttime. But the fun part from my perspective, again, with this example, is that it's very dynamic in terms of you can drill between different departments. We have it so that the individuals at the charge nurse level can look at it and say, what's it looking like for them for the future state? But then also we can have it rolled up so our senior leaders and executives can take a look at it and see, how are we doing for hospital staffing potentially over the next 2 weeks into the future? And where is it we may have gaps? Where is it we may need to call in some travelers? Where are the areas of opportunity that we need to really focus on so that we can make sure we have the appropriate number of staff, but again, not being overstaffed as well. All right, so fairly quick overviews. Happy to answer any questions here, but we talked about COVID-19 and predicting the utilization, forecasting the hospital census for the ICU and inpatients. We talked about the supply chain purchasing engine, right? Optimizing so that we get the best bang for our buck with the least amount of transitions between products. And then finally, what we just talked about was the demand-based staffing. And so we were able to optimize staffing to match our patient demand based on historical patient data and forecast into the future. And with that, I'd like to say a very heartfelt thank you. And if you have any questions, we don't get a chance to discuss them during this session, please feel free to send me an email. And then I've also included that .com address, justinsmithphd.com, goes right to my LinkedIn address. And so I welcome you to connect on LinkedIn, and we can continue the conversation there. And again, thank you very much for your time, and I hope you have a wonderful day.
Wow, Justin, thank you so much. That was amazing. And I know this virtual audience is giving you a huge virtual round of applause.
Thank you.
Thank you so much for sharing with us today. For the audience, it's time for you to make your way to your next session. Along the way, make sure you accept your connection request and take some time to check out our amazing exhibits. Thanks so much, and we'll see you around.